Everybody, my name is LAHRS2020 from the Department of Electrophysiology, Heart Center Leipzig in Germany. And I'm delighted to be here today to talk to you about the question of how to assess risk of adverse outcomes in patients with atrial fibrillation. So, my dear friend Dr. Alberto Alfi talked about the risk assessment for atrial fibrillation in the previous presentation. So, we decided that I talked more about risk assessment for adverse outcomes after catheter ablation. My talk is divided into two main parts. First, I will talk about how to assess risk of AF recurrence after catheter ablation. Then I will talk about how to assess risk of complications after catheter ablation. Before starting my presentation officially, I would like to just show you this slide. As you know, in the current ESC guidelines, which have been published recently, much more emphasis has been placed on the role of catheter ablation. Now, catheter ablation takes on a more prominent role for rhythm control and is recommended after one antiarrhythmic drug therapy failure. In 2016, the class of recommendation was 2A, but now it is 1. So it means that probably this increasing trend in the number of ablation procedures will be kept and it may even increase, which shows the importance of knowing more and more about the adverse outcomes after AF catheter ablation. You know better than me that AF catheter ablation is a well established strategy to maintain sinus rhythm in AF patients. However, AF recurrence is still regarded as a big challenge in the field of cardiac electrophysiology. According to the available data, post ablation AF recurrence takes place in 30 to 50% of the cases, so we should undoubtedly consider it as one of the most important frequent adverse outcomes. But why it is really important? Because we need to inform patients before the procedure about the possibility of this outcome. By the way, for a good and informative conversation with patients, we need to know the major risk factors and how to deal with them. So, a number of risk factors for AF recurrence after AF catheter ablation have been identified. Some factors are associated to cardiac related issues, including left atrial size, substrate visualization by means of MRI, or left ventricular dysfunction, or increased epicardial adipose tissue. Moreover, several biomarkers such as BNP have been introduced to predict AF recurrence. However, none of them have been highly recommended by the current guidelines yet. Older age and female gender are also two other factors which are identified to play an important role. Although these aforementioned factors are important, but we cannot really control them. To put it more simply, these factors can be used only to predict AF recurrence, but we cannot easily modify them. But fortunately, we have some other risk factors that are not only predictive but also can modify them. We can modify them to decrease the adverse outcomes after ablation. So we call them modifiable risk factors. This leads me to my next point, which is the role of modifiable risk factors for AF recurrence. The presence of comorbidities such as hypertension, sleep apnea, or obesity may influence the outcome of catheter ablation. So, when we are talking with our patient, we should always consider these risk factors. Um they may really increase the risk of AF recurrence and we need to inform our patients prior to ablation. Mainly hypertension and obesity are identified to be strong risk factors and independently predict AF recurrence after ablation. For the sleep apnea syndrome, different studies have also shown it's a very important predictive factor independently of obesity or left atrial size. In the current guidelines, uh, I would like to draw your attention to this slide because I think it's really important that the current guidelines recommend weight loss in obese patients with atrial fibrillation, particularly those being evaluated for ablation because it's an important strategy to reduce the risk of AF recurrence. Besides good blood pressure control in patients with atrial fibrillation and hypertension, to reduce AF recurrence and other adverse outcomes, such as stroke and bleeding, is also highly recommended in the current guidelines. For sleep apnea, there is also a recommendation to manage it in order to reduce AF recurrence. However, the level of evidence has been decreased in comparison to the previous guideline. I would like now to move on to the next part, which is about the clinical scores. When we talk about clinical scores, we always think that they should be really helpful. But is it really the case? Let's see the next slides. During the previous years, different clinical scores have been suggested to stratify the risk of adverse events and to predict treatment success in AF patients undergoing catheter ablation. In this slide, you can have an overview of currently available scores. As you can see here, some factors such as gender, older age, left atrial size, and AF type are common among the scores. And in almost all the scores, very simple variables are included. Indeed, it is very good. It really increases their popularity. But it should be emphasized that some of these scores are not only restricted to AF recurrence prediction. As you can see here, prediction of some other negative events, such as major adverse cardiac events or even low voltage area, is also recommended to be possible with these scores. In order to answer to our question whether we can really rely on this score or not, let's have a quick look at this recently published meta-analysis. In this meta-analysis, the performance of different risk scores was assessed. 33 studies were included, and the final results show that none of the scores had consistently poor or good performance. Therefore, as a conclusion, they suggest that clinical risk prediction of AF ablation has potential, but there remains a need for robust evaluation of risk factors and development of risk scores. The ESC guidelines have also a similar opinion, and it is said no single score has been identified to be superior to the others. Let's now turn to another factor, AF non-inducibility by pacing. We usually hear about the importance of AF non-inducibility after ablation, but honestly, until months ago, there was no cumulative evidence supporting the association of AF non-inducibility after ablation and freedom from AF. But in July 2020, a meta-analysis was published to answer this question. The authors aim to determine whether AF non-inducibility by pacing after catheter ablation is associated with reduced AF recurrence or not. In this study, 12 prospective cohort studies were included, and they showed that AF non-inducibility by burst pacing after catheter ablation is associated with reduced clinical AF, clinical recurrence of AF. And finally, they recommended AF more than 1 minute for AF non-inducibility. For AF inducibility, of course. Let's begin the second part of my presentation, which is very short. And like any other procedure, we expect complication after AF ablation as well. According to the available data, about 4 to 14% of patients undergoing AF catheter ablation experience complications. However, 2 to 3% of them are potentially life-threatening. Here you can see a list of common complications after AF ablation. It is recommended to know that, or better to say, it is really important to know that these complications occur mostly within the first 1 day after the procedure, but some may happen 1 or 2 months after ablation. We have to remember that peri-interventional death is really rare, but if it happens, it is usually related to cardiac perforation, cardiac tamponade. In a recently joint publication, which was the joint expert consensus, a close monitoring in the first 1 month after the ablation was recommended. As just mentioned before in the previous slide, cardiac perforation is a leading cause of death after ablation, although it is uncommon but potentially fatal. Um, in a recently published study on more than 100,000 patients who underwent AF ablation, factors associated with cardiac perforation were assessed. In this study, cardiac perforation was defined as hemoprecardium, cardiac tamponade, and precardiocentesis within 30 days of AF ablation. In this study, patient risk factors for cardiac perforation were female sex, obesity, absence of ICE intracardiac echocardiography. And they finally generated the score, a risk score, with the following point assignments. Female sex 1 point, obesity 1 point, and non-use of ICE. And previous cardiac surgery, surprisingly, minus 6 points. I think it's an interesting study that we can use in our clinics to predict the risk of cardiac perforation. So, this slide brings me to the end of my presentation. Thank you very much for your attention. For any further questions, please feel free to write me an email or to send me a message on Twitter. Thanks.